Hi, my name's Bill Abraham, professor of medicine at The Ohio State University, and it's a pleasure to participate in this meeting on top 10 topics in clinical cardiology. I'll be discussing cardiac contractility modulation at the intersection of EP and heart failure. First of all, what is cardiac contractility modulation? Well, shown here are CCM signals, which are relatively high voltage, biphasic electrical signals that are applied to the heart during the absolute refractory period of the cardiac cycle. As such, these electrical impulses are non-excitatory, but they perform a number of favorable effects on the heart that result in an improvement in cardiac contractility, without any increase in myocardial oxygen consumption or work, thus improving the efficiency of the heart as a pump. CCM is delivered by an implantable pulse generator, much like an implantable cardiac rhythm management device, such as an ICD or a CRD device. In contrast, though, it has a rechargeable battery, and thus a very long battery life. There are two right ventricular septal leads that are used for sensing and for CCM signal or impulse delivery. The signals affect the biology of the failing myocardium, specifically genes, proteins, and phosphorylation, in a way that improves cardiac function. As mentioned, an increasing contractility with no increase in myocardial oxygen consumption. As shown on the slide, it's important to note that these biological effects are seen rapidly in the region of signal application, but it has been demonstrated that the biological effects are seen remotely in the left ventricle over time. Mechanistically, CCM improves myocardial gene expression in the failing human heart. The results shown on this slide look at the expression of multiple heart failure-related genes, which improve with cardiac contractility modulation. These findings come from human myocardial samples from a double-blind randomized controlled study employing serial endomyocardial biopsies at baseline and at follow-up to examine changes in gene expression. Importantly, you will see that during the period in which CCM was turned on, there was a favorable effect on those genes which are associated with improved cardiac contractility, particularly those involved with calcium handling, such as SERCA2a, phospholambin, and others. This translates into an improvement in LV structure and function over time. In studies from both humans as well as animals, CCM has been shown to improve ventricular volumes and the left ventricular ejection fraction, as shown on this slide. On the upper figure in this slide, moving from left to right, you can see the important reductions in LV end diastolic and end systolic volume, and the approximate 6%, and this is an absolute percentage point improvement in the LV ejection fraction. Similar changes shown in another study shown on the lower right-hand corner of this slide. And finally, it has been suggested that CCM has a favorable effect on sympathetic activity in heart failure patients. Here you can see suggested mechanisms by which CCM may influence sympathetic activity. For example, CCM increases septal contraction. Mechanoreceptors then may activate vagal afferents. Sympathetic activity decreases, and there's an improvement in overall autonomic balance. Is there an evidence for an anti-adrenergic or sympathetic effect of CCM in heart failure patients? Well, there is. In this study from Chope and colleagues, which demonstrates the effect of CCM on sympathetic nervous system activity as measured by muscle sympathetic nerve activity. On the left-hand side of this slide, you can see baseline results for muscle sympathetic nerve activity in the bottom panel of the slide. You can see that there is quite a bit a heightened state of sympathetic nervous system activity in this patient, as is indicative and seen consistently in heart failure patients. Following 3 months of cardiac contractility modulation, there is a reduction in muscle sympathetic nerve activity or nerve bursts associated with CCM therapy. Well, what does all of this translate into from a clinical or patient-oriented standpoint? Well, first of all, prior to the FIX-HF5C or confirmatory study, there were 3 relevant randomized controlled trials that demonstrated the significant impact of CCM on exercise ability and quality of life. These trials included the FIX-CHF4 study, a randomized double-blind trial performed in the European Union, the FIX-HF5 feasibility or pilot study performed in the US, and the FIX-HF5 larger and pivotal randomized controlled trial also performed in the US. These studies demonstrated quite consistently marked improvements in peak VO2 during metabolic exercise testing, compatible with a marked improvement in patients' exercise ability and functional status. And in a pre-specified subgroup analysis of the FIX-HF5, we saw that the greatest benefits were seen in patients with mildly to moderately reduced LV ejection fractions, ranging from 25% to 45%. And this was the population of patients that we carried forward into the FIX-HF5C confirmatory study. Well, first, let me share this observation with you. This data comes from the FIX-HF5 study, looking at the difference in change in peak VO2 over 24 weeks of follow-up. And you can see, as highlighted by the yellow shading on this slide, that those patients with LV ejection fractions of at least 25% or greater demonstrated the most marked improvements in peak VO2 with cardiac contractility modulation. So now let's take a look at the confirmatory study, the FIX-HF5C study. This is the study that ultimately led to US regulatory approval of cardiac contractility modulation. This was a 160 patient randomized trial performed at 20 US sites and 8 sites in Europe. The target population was heart failure patients with ejection fractions ranging from 25% to 45%. The primary effectiveness endpoint was an improvement in peak VO2. The primary safety endpoint is outlined on this slide. The major secondary efficacy endpoint was quality of life. And it's important to note that this trial was done under the auspices of the US FDA's Breakthrough Devices designation. To make a long story short, the FIX-HF5C trial was markedly positive. Here is the primary result of between group difference in peak VO2. You can see that compared to control patients, the CCM patients had on average a 0.84 ml per kilogram per minute improvement in the peak VO2. To put this into some clinical context, exercise training for patients with HFrEF improves peak VO2 on average by about 0.5 ml per kilogram per minute, and cardiac resynchronization therapy improves peak VO2 in patients with wide QRS complexes on average by about 0.8 to 1.0 ml per kilogram per minute. So this finding compares very favorably to other approaches and other device-based therapies for the treatment of heart failure. In addition, In the FIX-HF5C trial, CCM significantly improved quality of life and functional status. Let's start first on the left-hand side of this slide with the changes in the quality of life score. Here, using the Minnesota Living with Heart Failure questionnaire, there was an 11-point between group improvement in quality of life seen in CCM patients. Remember, with this particular quality of life instrument, a lower score is a better score. It's associated with an improved quality of life. And this 11-point between group difference also compares very favorably with other well-established heart failure therapies. For example, drug therapies in heart failure improve this quality of life score on average by about 3 to 5 points. And cardiac resynchronization therapy, again, in the CRT indicated population, improves this quality of life score by about 9 or 10 points, showing again how favorably CCM compares with well-established heart failure drug and device therapies. And then, as shown on the right-hand side of this slide, as judged by the clinician, according to the New York Heart Association functional class ranking, more CCM patients improved by at least one New York Heart Association class when compared to the control group in the FIX-HF5C analysis. In addition, a pre-specified subgroup analysis of the FIX-HF5C trial demonstrated significant improvements in peak VO2, quality of life score, and New York Heart Association class, regardless of ejection fraction. In both HFrEF patients, those with ejection fractions less than 35%, and what we might call the HFmREF, or mid-range or mildly reduced EF patients with ejection fractions ranging from 36 to 45%. There were significant clinical effects in both groups of patients. And finally, CCM may improve outcomes. The data shown on this slide, looking at the combined endpoint of cardiovascular death and heart failure hospitalization, comes from a combined analysis of the FIX-HF5 and FIX-HF5C studies. Here you can see a statistically significant better outcome, a reduction in this composite endpoint in CCM versus control patients. Now, neither of these trials were prospectively designed or adequately powered to look at this endpoint, so this observation should be confirmed in future studies, but it's important to note that there have been published other more recent and mostly observational trials that demonstrate improvements in clinical outcomes with cardiac contractility modulation. So let me summarize what I've said thus far. First, based on the totality of clinical data in New York Heart Association Class 3 heart failure patients with HFrEF and HFmREF, that is with LV ejection fractions ranging from 25 to 45%, CCM improves exercise capacity, quality of life, and functional status. It shows strong trends toward improvement in morbidity and mortality, especially in reduction in heart failure hospitalizations. And it has an acceptable rate of device or procedure-related complications, which is similar to that seen with cardiac resynchronization therapy. These effects are seen in both HFrEF as well as HFmREF patients, and thus CCM is a valuable addition to our armamentarium for the treatment of heart failure, especially in HFmREF, where no effective drug or device therapies exist. Now, let me update you on the current regulatory status of cardiac contractility modulation, because this has become a device-based therapy that can be used in your patients across many geographies around the globe. CCM has been CE marked and commercially available in many countries outside of the US for quite some time, and there is an extensive post-market experience with the use of CCM in the European Union. On March 21st, 2019, about a year and a half ago, the FDA approved CCM for use in the United States. The indication is as follows. The Optimizer Smart System, which delivers CCM therapy, is indicated to improve 6-minute hall walk distance, quality of life, and functional status of New York Heart Association Class 3 heart failure patients who remain symptomatic despite guideline-directed medical therapy, who are in normal sinus rhythm, and who are not indicated for CRT, and finally, who have an LV ejection fraction ranging from 25 to 45%. Now let me cover just a few frequently asked questions, and then I'll conclude with an algorithm for the use of cardiac contractility modulation therapy. First of all, who prescribes this therapy? Well, really any clinician who takes care of New York Heart Association Class 3 heart failure patients can refer patients for cardiac contractility modulation. Who implants the device and performs the procedure? Well, here's where we come to that intersection between electrophysiology and heart failure or general cardiology, because it is our electrophysiologists who implant CCM devices or those skilled in the implantation of cardiac implantable electronic devices. What's next for this therapy? What does the future hold? Well, there is ongoing development of a combined CCM ICD device, and also trials will soon start, which may expand the indication for CCM to other heart failure populations, perhaps those who are less sick or those with even more preserved or higher LV ejection fractions. And then finally, who should really receive this device? Well, I think those who are indicated in the FDA label and where the focus of studies such as the FIX-HF5C study are ideal candidates for this therapy. And that includes heart failure patients with class 3 symptoms, despite optimally tolerated guideline-directed medical therapy who are not candidates for CRT. And finally, let me conclude with this simple algorithm for who should receive this therapy. So those patients just mentioned on the prior slide, heart failure patients with New York Heart Association Class 3 symptoms, despite optimally tolerated guideline-directed medical therapies. If that patient has a CRT indication, a wide QRS complex, particularly a class 1 indication, such as a very wide left bundle branch block, that patient should receive a CRT device, either a CRT pacemaker or a CRT defibrillator. If the patient does not have an indication for CRT, then there's an additional question to ask. What's the ejection fraction? If the ejection fraction is less than 35%, that patient should have both a CCM device as well as an ICD device. And if the answer is no to that question, if that patient falls in that LVEF range of 36 to 45%, then that patient is a candidate for a standalone CCM device without a concomitant ICD. I want to thank you very much for your attention.